Hello everybody and welcome to our Ask the Expert webinar this evening. I'm Martine Wormsley and I'm Head of Research Strategy at PSC Support, and I'm really delighted to be joined here once again by Dr. Palak Trivedi. He's the consultant hepatologist at the Queen Elizabeth Hospital in Birmingham and leads national and international PSC research, not least this Fargo clinical trial that we're going to talk about this evening. I'm also very pleased to introduce you to Sarah Al-Shakhshir, and the clinical research fellow who is also delivering the Fargo trial at the Queen Elizabeth. So those of you who attend the QE in Birmingham may already know Sarah. So welcome to both of you.
Thank you for having us.
Also got Mark Chatterley here, who's our admin manager, and he's going to be in the background this evening, maybe answering a few questions and putting links in and just making sure everything's running smoothly for us. So thank you very much for that, Mark.
I'm just going to find a way. I need to open up the questions and the chat to people. So I'm going to disappear off the video and get that working.
Fantastic. Thanks, Mark. So tonight's Ask the Expert is about the Fargo trial. And so Sarah and Palak are going to tell us a little bit about it, and then we'll open up to some questions. And as Mark said, you should be able to click on the Q&A button and then type your questions in. Please do try and keep your questions short so that we can take as many as possible. And as always in these sessions, neither Sarah nor Palak can give individual medical advice, can only be general information. But we would like to try and keep this sticking to the Fargo trial questions. So that's enough from me. Over to you, Sarah and Palak.
Thank you very much. So thank you everyone for joining us today. So we're here to talk about the Fargo trial. And for those of you who don't know what that is, it's a trial that involves changing your gut microorganisms, your gut bacteria, fungi, viruses, and replacing those with organisms derived from people without evidence of liver disease or inflammatory bowel disease. And the objective by doing that is to not specifically settle gut inflammation alone, but because of the evidence that your gut microorganisms might be the cause of PSC developing in the first place, it's to improve what your liver's doing. So the objective is to improve your liver health as well as your gut health. And we will talk a bit more about specifics in a moment, but we are measuring a variety of parameters as part of this study: your liver blood tests, markers of scar tissue formation, your quality of life, symptoms, and what's going on from a bowel disease perspective. Now, in terms of how we identify whether people have got good microorganisms, good enough to give to people who decide to take part, it's a very rigorous screening process. So we have a established donor screening program wherein about only 20% of people who feel that they're healthy and want to donate stool, where we get the organisms from, can actually take part. And we want that rigorous screening program because we don't want to give things to people if the donors have a medical history that is slightly checkered, either themselves or their family history. So people, for example, with family histories of liver disease, bowel disease, but also family history of certain types of cancers, people whose diets are slightly more irregular or bowel habit is more erratic. So the selection of donors is very carefully screened, and the actual donation process for stool takes place once a day for over 10 days. So we're absolutely sure it's a good product to administer to people, and then that product is then cleaned, homogenized, so sort of made into a preparation, checked, and then batch released. So it undergoes more of a rigorous screening process, I would argue, than some of the tablets that we put into our bodies for other indications. So with that, I'll sort of hand over to Sarah just to sort of talk a little bit about the study design, the type of people who will be eligible to take part, and the treatment schedule for it, and the trial schedule. And we can then open up the floor to your questions. So I'll hand over to Sarah.
Great, thank you, Palak. So this study is what we call a randomized controlled trial. And what we're aiming to do is recruit a total of 58 people and assign them to either having our intervention, which is the fecal microbiota transplant, or a placebo, which is essentially saline or just liquid that shouldn't really have much effect on anything. We are blinded to who is assigned to which arm. And it's only the people doing the colonoscopy and a few of the nurses that will be aware of what treatment each person has received. The population that we are aiming to recruit are mainly patients who have both PSC and inflammatory bowel disease, those over the age of 18, and those who may have fibrosis, but either in the early or moderate stages. So at the moment, we're not looking at anyone with advanced fibrosis or cirrhosis. And that's more or less for safety reasons and to ensure that the patients will be able to continue with us throughout the entirety of the trial. There are a lot more rigorous eligibility criteria, but those are essentially the main ones. And what we will aim to do is we will follow you up over a period of 48 weeks. In the first 8 weeks is when you receive the treatment. The first treatment will be delivered through colonoscopy. And what we're trying to do is match up the colonoscopy to when the patient would be having their annual colonoscopy anyway, so that we're not subjecting you to more investigations, more interventions unnecessarily. And what we'll do is essentially perform your screening colonoscopy, make sure there's nothing there that we need to worry about or remove, take some biopsies as a part of that, and then administer the FMT in liquid form on the way out. We'll collect a whole other number of other samples, such as blood, urine, stool samples, alongside the biopsies from the colon, and we'll analyze those separately. But then we'll bring you a week later so that we can administer some more FMT through enema form, and that will be done by the nurses in our clinical research facility, and we'll continue the enemas for a total of 7 weeks. The rest of the time in the trial will be mostly follow-up, but you will have to undergo a sigmoidoscopy at week 12, so just a mini endoscopic procedure so we can have a look at how things are going, take some more samples, and then towards the end of the trial is when you'll have your hopefully second annual colonoscopy, and that's at week 48, slightly earlier, but hopefully shouldn't be too much of a bother. And like I said, throughout the trial period, we'll be seeing you quite regularly, taking lots and lots of samples from you, and we'll be analyzing these samples to see how things are changing. But alongside that, what we're also looking at are markers of your liver disease progressing, regressing, stabilizing. So we'll be looking at liver tests. We'll be doing fibrous scans to see what the fibrosis scores are doing. And we'll be also looking at what we call patient-reported outcomes. So how you're doing, how you're feeling. And that's something that we can always expand on further. Anything else I've missed, Palak?
No, I don't think so. So
no,
I think that's fine. So just to summarize, this is a trial which will, if people who participate, which people will enroll for about 48 weeks, and we do have a give or take period because 48 weeks we can't be exact for everybody. So over the course of a year, and the first treatment will be administered at time of your scheduled colonoscopy for those individuals who have inflammatory bowel disease. So this trial is specific to those people with PSC who've got colitis, and it's a once weekly treatment for the first 8 weeks, first by colonoscopy, and then once weekly for another 7 weeks via enema. And then we see you at intervals thereafter every few months to monitor your blood tests, ask about your quality of life and symptoms through specific questionnaires that were chosen actually by PSC support members. And we will then measure at the end of that year what the effects of that treatment very early on has done to your liver blood tests, the quality of life, markers of liver scar tissue formation, and inflammatory bowel disease activity. So with that, we're very happy to sort of take any questions either from Martine, Mark, or those on the call.
Thank you very much both for explaining that. And we've got a few questions coming in already, and we've received some ahead of time too. And I will focus on the questions about Fargo trial first, because there are some general ones, but I think we'll leave those for now. So the first one is, I understand from literature that there is some evidence of increased weight gain from feces transplanted from obese donors. Is this true?
That's a very good question. So just as a bit of background, as with many advances in medicine, a lot of work, a lot of learnings in this field have come from animal studies, predominantly mice or rats. And there is evidence in both ways that if you have an animal model of obesity, which is sort of fed what we call like an American lifestyle induced obesity type diet, because American diets are much more rich in things that are bad for you than British diets, for example, then you can induce obesity in animals. And you can take the stool from those animals and give them to lean mice. And just by doing so, by keeping the lean mice on the same diet, you can induce obesity. And the converse is also true. You can take an animal model of obesity and you can actually give stool from a healthy mouse and reverse that or prevent that that complication. When it comes to man, the data is much less clear because we can't control what sort of humans do. But there is certainly some evidence in people who have fatty liver disease, or what we now call metabolic dysfunction associated steatosis. And you can improve certain parameters by giving stool from healthy individuals. We haven't in humans given, well, willingly given donor stool from people who are obese or who have metabolic risk, because that would be unethical. And going back to the donor screening, one of the criteria amongst our long list is actually going to be or actually is, not, I'm not saying it's going to be, it actually is body mass index. So the donor screening, you have to be below a certain body mass index and have a certain dietary profile that minimizes what we perceive at these in 2024 as a bad diet. Those things would exclude you. So we're not going to be giving donors from people who are obese, overweight, or who have bad dietary profiles.
Thank you. And the centre that does the screening is at Birmingham, isn't it? I understand it's quite a national centre of excellence for screening poo.
No, so there are several labs around the world that can provide fecal transplantation as a product for trials. Now, I'm only going to talk about what happens in the UK here, because internationally we have less control. But yes, Birmingham is the only centre in the country that can provide stool for clinical purposes. So in people who have antibiotic associated diarrhea for prolonged periods, what we call Clostridium difficile infection, we are the only centre that can make stool for that purpose and provide it nationally as a service. There are centres like King's Hospital, in addition to ours, who can generate it for clinical trial purposes. And so we were the first one. King's also do it for their trial in people with very advanced liver disease. They administer it in a different way, and they have their own screening protocol. But despite being a trial site for this study, they will be taking stool from us in Birmingham. So everything is going to be done from Birmingham and shipped to the centres that are taking part, of which there are 5 additional to our own.
And that's so that you can keep control of more or less everything to do with the trial.
Yeah, so just so we're comfortable that things have been screened properly and we take ownership over anything that may or may not happen.
And so we've got no chance of ordering perfect poo or anything like that if we're on the trial.
No. So everybody will get that sort of that same standard. So everybody will get the same standard. But yes, you're right. You can't pick your donor is a short answer. So you can't choose either donor A or donor B. What we are going to do though, so one donor will be able to donate to multiple recipients. So if there are 5 people who want to take part in the study, one donor may, depending on how much they produce, be able to donate to all of those individuals. What we are not doing, though, is mixing donors for one recipient. So we're not going to have 3 donors for one person to receive, because we won't know what happens. And one of the main research objectives of this trial is to find out what is it in a good person, in a good stool donor, that makes a difference, because there may be somebody that we think at the moment is a good donor and a second and a third person who's equally good, but the results that we see in people are going to be different. The blood results may change to a different degree. The way that they make people feel may change. So one of the what we call translational research objectives is to try and find out what pathways have been activated or switched off, which are associated with that effect. So we should later on in future be able to refine that window, not just to see what the stool looks like in terms of composition and purity, but functionally, how is it different? Because we're all different as individuals, and the donors will all be different to one another.
This trial then is more than just does FMT help people with PSC. It's you're looking into generating some really, really rich data about what's going on, aren't you, and why it might be helping.
Yes, exactly. So, for example, we're aware that certain medications that we use in day out work to treat diseases, otherwise we wouldn't use them. But you'll be surprised to sort of learn that even many medications that we've been using for decades or centuries, we find that there are certain active parts of them that are more beneficial than others. For example, steroids, which some people may have received for treating their inflammatory bowel disease, or that we were using quite often during the peak of the COVID pandemic. They are very good anti-inflammatory medications, but they have lots of side effects. And still now, we have not managed to, I wouldn't say identify, but develop a slightly purer, more targeted steroid for treating inflammation without its particular side effects. Now, I'm not for a second saying that stool transplantation is going to have side effects as we see with steroids. But what I'm saying is that different people are going to react to this in different ways. They're going to have different benefits. So far, there are no bad safety signals or toxicity signals that we've identified in our program here in the UK at all because of our screening program. But if we find that certain elements of a stool product have greater benefit than others, then in future we might be able to develop a more pure or refined medication that contains only that bit without bits that have no effect.
That's the dream, isn't it? That would be really good.
Yeah.
Thank you. So the next question here is, are patients with a J pouch eligible to join the trial?
Yes, they will be. Yes. So we will be including so our inclusion criteria will be people who've got colitis, and that will include people who've had an operation to remove their colon, and had what we, as Martina alluded to, what we call a J pouch formed, which is a type of rejoin of the remaining segments.
Good, thank you. And someone here says that they volunteered to go on the trial, but they were declined.
Oh, right.
But that's important, isn't it? Because there's certain eligibility criteria and inclusion and exclusion criteria. So some people can't, can they? And there's a reason for that.
Yes, every trial will have to get the right balance between what is deemed eligible criteria and what is deemed ineligible criteria where you can't take part. And the trial hasn't opened. Well, I mean, it's going to open this week, but in Birmingham. So we have not definitively said no to anybody, but according to our current protocol, there will be some people that automatically we know will be excluded. For example, if you've got completely normal liver tests, if you've had a liver transplant, if you have had bowel surgery and you don't have a pouch and you've just got you still have a stoma bag, for example, as a general rule, those things would not allow you to take part in the study. Because some of the changes in the gut microorganisms that we're targeting, we've so far, based on our data, are very early on in the process of PSC. We are not permitting entry for this trial. There will be another one later, which we can talk about at the end, perhaps, to people who've got very advanced liver disease already, where the disease is likely to have been present for some time, i.e. people who've got cirrhosis. Those people, we don't feel that this trial at the moment would benefit as much. That may change as we get more data.
That's a really good point. If you're not eligible for one trial, it doesn't mean that you're not eligible for all of them.
Yes, that's right. Yeah.
Yeah, I think I'll ask about that other trial in a little while. Yeah. But something you did just say a moment ago, very casually, you said, oh, it's going to be opening in Birmingham this week. We hope. That's exciting.
Yes, yeah, very exciting. So I communicated with our trial manager this morning. It's literally just a signature or two from the head of our trials unit, who's currently on leave. As soon as they return, it's on their desk first to be signed, and then yes, we can get the green light. And Sarah has kept a log of everybody so far that we've identified who has been deemed eligible from Birmingham and who has expressed interest in the study, and we can send everybody out what we call a participant information sheet to read. And then, because some people may say I'm really keen, but when they read things, there may be some things there that you don't like, and say actually the visits are a bit too frequent for me, or there may be something that hasn't come out in preliminary discussions. So as Sarah alluded to, in addition to your routine colonoscopies at the start and then 1 year later, there is a 12-week sigmoidoscopy, which is not a full colonoscopy. It's just looking at the tail end of the bowel to get samples so we can see and make some assumptions based on the data whether the stool has been engrafted and stays that way. So some people may say, actually, I don't want to have that extra procedure. So it's important that when we get the green light, then and only then we send out those information sheets to those who've expressed interest.
Yeah, thank you. And people are encouraged to read them and ask people questions, find out more.
Yeah, absolutely.
Check what's going on. Thank you. So there's a question here about cirrhosis. So earlier on, Sarah, I think you said if someone's got cirrhosis, they won't be eligible. And they're asking, are you able to specify any specific criteria level for the liver cirrhosis? Is there sort of a cutoff where you wouldn't be allowed in?
Yes, so in our protocol, we have specified cutoff levels, and it depends on the modality that we're assessing for cirrhosis. So for example, if we're doing a FibroScan, the jelly scan on the tummy, then a score of more than 14.4 would disqualify the patient from the study, unfortunately. If they've had a biopsy, for example, that has shown advanced fibrosis, then again, that would disqualify them from that. And obviously, if there's any clinical or biochemical markers to suggest that they've got advanced cirrhosis, then again, that would mean they're out of the running, unfortunately.
But you have something up your sleeve for a different trial for people with cirrhosis.
Yeah, perhaps at the end, yeah.
Do you only want patients from the UK on this trial?
We would like to have anybody and everybody from elsewhere, but legal barriers would preclude us from, prevent us from allowing people who do not have a UK general practitioner and a UK NHS number, unfortunately. So at the moment, the nature of this trial it only allows us to conduct in the UK. When we apply to do these trials, we have to apply to a research funder, which includes PSC support in this case, as well as LifeArc, which are a fantastic foundation for funding a whole array of rare diseases. And we've got a number of grants now sort of with LifeArc, which we're very grateful for. But when we try to do these sorts of studies, the sort of funding that we would need to open international sites is orders of magnitude greater. So it would cost, I mean, this sort of trial cost, will cost just over £1 million to deliver. And we don't see any of that as, Sarah and I's salary. It's not reflected in our salaries in any way. It's purely to set up the trial. All the regulatory hurdles cost money. Our trials unit to run will cost money, statisticians, etc. And to run internationally, there are additional charges. So it would cost, at least 4 or 5 times as much to do that, and most public sector or charity funders won't have pockets that deep, nor will they be able to support us in that venture. However, when we have trials conducted at a local level that have promising results, yes, we can open the doors to international opportunities, but often that requires a pharmaceutical collaborator, big pharma, to provide support. So at the moment, we sort of, unfortunately, this trial is not available outside the UK. Well, it's not available to deliver outside the UK, nor is it available to people who live outside the UK without a UK general practitioner and NHS number.
Yeah, so you need to be someone that's getting NHS care already.
Yes. And part of that is because we keep in touch with general practitioners when people take part in trials, and if you're not registered, it's a bit difficult. So you don't have to be a British citizen in any way, but provided you're eligible to receive NHS care, that's absolutely fine.
Okay, good, thank you. Next question. In some of the studies of this type carried out overseas, participants have taken probiotics in addition to the fecal transplant. Was this considered in this trial?
So it was considered, and I know that Martin, you and I and others had sort of had exchanged a variety of correspondence in this regard. So it was considered. We are not allowing people in who are on commercial probiotics, so that does not include things like Yakult, natural yogurt, and so on and so forth. No, not so. So dietary probiotics. I mean, by all means, check with your consultant who's doing the trial. those will be fine. But what we would consider therapeutic probiotics that people take to improve or treat disease, like Simprove or VSL3, would not be permitted. That's mainly because that is a microbial product and the fecal transplant is a microbial product. And if we are to see an effect, positive, negative, or nothing, we wouldn't know, because if there's an interaction or a cancellation between what we're giving with the probiotic you're taking. So it will, so the pure reason that we're not allowing people in is we would not be able to interpret our results correctly. If we were to redesign this particular trial specifically to allow people in with probiotics, then everybody would have to take the probiotic, as well as, you know, either the treatment arm or the placebo arm, and that probiotic dosage would need to be standardized in order for us to interpret what's doing what, really.
So if somebody, because I know people do buy and take these things, yeah. If you are one of those people, but you want to go on the trial and you're potentially eligible, how could you just stop taking it for a certain amount of time and then have a chance at going on? How long would you want them to be off the?
So Sarah may have to help me out here. I can't remember I know for antibiotics what the window is, it's 12 weeks. But probiotics, I can't remember what the window is. I think it might be similar or less, but
yeah, I don't think we've specifically said each and every one. We've said 12 weeks blanket for all of them.
Yeah, so it's a 12 weeks. So it's a 12-week window where we've said other microbial products would have to stop. And the reason that we're allowing people in who take natural yogurt or Yakult or I forgot the other one that my kids are, Actimel, you know, sort of those products, is because the concentration, the amount of the quantity of cultures that are present in dietary supplements are, again, orders of magnitude less than in ones that we use to help treat active disease.
Yeah, thank you. That makes sense. Yeah, thank you. Yeah. If this procedure was found to stop or reverse PSC, given the risks of recurrent PSC for transplant patients, do you see any reason why transplant patients would not be able to receive such a treatment as a preventative measure in the future?
I don't see any reason why they couldn't receive it, but we would have to prove that it works as a preventative treatment. So if we find that it has benefits, treatment benefit in people with PSC at the moment, in this particular trial, which is the whole objective, then we could say this helps treat people who've got established PSC. What we cannot say, though, is that it would have prevented people developing PSC, because that's not what this trial is designed to do. So in order to do that, we would have to do one of two things. One is identify a group of people who are very likely to get PSC, which are often young people with inflammatory bowel disease alone, and see whether fecal transplantation reduces the chances of them getting PSC in the first place. Or, as this individual is asking the question, people who've been transplanted for PSC, and we know, I mean, I know this is slightly off topic and may cause some concern, but we know that about 1 in 4, 1 in 5 people can develop recurrence of their PSC after transplantation. So we would then have to design a trial where we give this particular treatment, and we would have to determine how often we give this treatment and see whether we can lower that value from that 1 in 4, 1 in 5.
Yeah, and that's a really important group of people as well, isn't it? They've already been through enough with PSC. Absolutely. So if we can stop anything happening again, that would be amazing. Well, there's a research project to design. Next question. Oh, they just all jumped about. Next question. Considering the gut-brain axis, do you screen the donors and their families for any brain degenerative diseases?
We ask about them in the personal history and in the family history, and anybody who has a history of or is currently taking any mental health related medication, those people would not be allowed to donate, or I think they could donate, but we just wouldn't use them. So we ask about it, but we do not routinely screen donors with MRI scans or DAT scans or other forms of imaging, nor do we put them through a full diagnostic algorithm for example, all the different diagnostics that you would need to do to make a diagnosis. So we ask about it, we do a mental health check for mood. I don't like using the term disorders, but mood-related affective conditions, as well as their family history. And but we don't perform any diagnostics to exclude things in the absence of a diagnosis.
Thank you. Next question. What is the expected outcome from Fargo, i.e., what's the hypothesis?
So the hypothesis is that in people who receive fecal transplantation, the magnitude of reduction / normalization in liver blood tests would be significantly greater than people who receive placebo, so the inactive treatment. That's the primary outcome measure. There are a wealth of secondary outcome measures. In a similar vein, the magnitude of reduction or the proportion of people who have stable circulating and imaging markers of fibrosis or scar tissue would be greater than the people who have received in the treatment arm versus those with placebo. So we are hoping to see a greater benefit in those markers. And thirdly, we are looking to see whether the quality of life improves in people who receive fecal transplantation more so than it does in people who receive placebo. And what we call the translational research objectives beyond liver biochemistry, markers of scar tissue formation, and quality of life are looking at looking at what factors determine good engraftment, how many treatments do we need in people with PSC and colitis, and to change functionally what the gut microbiota are doing. And there are certain newer biomarkers of PSC disease progression, which we're also going to be collecting and measuring, that are not usually captured clinically. They're very much research tools, but they've shown promise at predicting who's going to do well, who's going to do badly. And we are going to capture those markers, what they're called PRO-C3, PRO-C5, PRO-C6, and there are a handful of others. And we're looking to see whether they remain stable or fall more so than in the people who receive placebo, where we expect, based on previous studies, for them to rise as time goes on.
So do you think, you might not be able to answer this, so I'm being cheeky asking, but if you're on the trial, say you've not got the placebo, you're getting the real thing, do you think people would notice a difference in themselves?
Well, I hope so. I mean, so when we measure quality of life it's not just one tool that we're going to use. So there will be a global assessment, and Sarah may want to come in here as just to comment on the quality of life tools that we're using and what each are measuring. But so one of the objectives is to see whether people feel better. Now, the people who are going to administer the fecal transplantation are going to be different to the group of doctors and nurses who are going to be performing the assessments. So I will be performing the assessments, Sarah will be performing the assessments, but it'll be different colleagues administering the treatment. So we're not going to know who has received what treatment. Now, it's very difficult to make saline look like stool. I mean, they look different, they smell different, the consistency is very different. And we are mindful that we can't, what we say, blind people completely, but even those people who receive it, there will be a screen in front of where in between the monitor where you have your colonoscopy and when we're administering the products, so you will not be able to see the color of what's coming in. Of course, you may be able to smell it. That is absolutely true. But because you would have just had a colonoscopy, we are slightly pragmatic in that the room may already smell of stool by during that procedure. So we've got as much as we can to try and be sure that everybody is blinded as to what treatment arm they're in beyond those administering it. So even the quality of life metrics, was if somebody says, I know that I've had the active treatment, if somebody feels in themselves that they feel no different, or they really, really feel that they are different, we will capture those quality of life metrics in addition to the other markers of liver disease severity and colitis severity. I don't know, Sarah, did you want to talk through the different quality of life tools that we're using, and just so people can get a flavor of what the domains that we're capturing?
Yes, I'm just trying to find them to remind myself which ones they are, because I know we're doing the itch 5D, I know we're doing the SI-BDQ, but I cannot remember the other two that we are doing.
They're quite complex, aren't they? But we'll let you go do that, and maybe we'll come back to you when you're
All
ready.
right.
But
It's going to be, it will be really interesting though, won't it, to see how people feel and function, because this has been done in IBD patients. And how long do they notice the effects for normally? Do you have a sense of that?
Yes, so in studies of colitis and inflammatory bowel disease, because the main determinant of those individuals' quality of life in those trials was their bowel disease, it was somewhat easier to capture, because does your colitis get better when it's very active? Now, people with active colitis is not a prerequisite for this trial. You just have to have PSC and colitis. Whether the colitis is active or not is a secondary issue. But in the colitis only trials, people notice a difference within days and weeks of improvement. Now, as with any treatment, I'm not going to say that effect is across the board, but what we have seen is that in people with colitis who've received this, this intervention, even if they've failed multiple more expensive advanced therapies like, what we call biologics, infliximab, vedolizumab, etc., people have been able to come off their medications when they've given a fecal transplantation, and they feel an effect, an improvement within just a few days or weeks afterwards. So that's what that Stop Colitis trial showed. One big piece of insight though was the number of inoculations that were needed did vary from person to person. So some people had good engraftment of stool within 1 to 2 inoculations. Others required up to 5 to 7 inoculations. So that's why we've gone for 8, because that's what was done in that trial. And to be honest, if people haven't achieved good engraftment of their stool or of donor stool by sort of 8 inoculations, it's that's quite a lot afterwards. And even if we're giving it via enema, not via colonoscopy each time, that's quite an undertaking for people to do. And if we require even more and more and more, I think that sort of goes beyond what is likely to be achieved realistically.
Yeah. Okay. Sarah, do you have any?
Yes, I can.
Report to us?
So we are doing 4 quality of life questionnaires in total. We've got the PSC patient reported outcome questionnaire, which some of you may be familiar with, which looks at the way that PSC affects your different aspects of your life. We've got the short form 36, which is a little bit more of a general quality of life questionnaire, which similarly looks at different aspects of your day-to-day life, activities, social, emotional, physical life. We've got the 5D itch, which again, some of you may have been exposed to in the past, which looks at itch as a symptom and how it affects you day to day, and similarly how it affects your ability to function in a day-to-day capacity, how it affects your things like your sleep, your ability to work emotionally, etc. And then finally, we have got the SIBDQ, which is an IBD quality of life questionnaire, which again looks at similar quality of life measures, but in terms of the way your IBD affects all those different areas. So those are lots of questionnaires for you to work through.
Thank you. And the itch one is not because we think people are going to get itch from this trial. It's just to record it in people that have already got itch, or to see, if there's anything changing.
Yeah.
And these questionnaires are all validated, and they're just helping make sure there's a standard systematic way of checking how people are doing on the trial. And hopefully, well, I won't say, we don't know what's going to happen, do we? So we don't want to influence how positively people report, but hopefully they will.
Yes, yeah. Because when we were choosing the amount of quality of life questionnaires to include, I mean, there's generally speaking, doing more than 4 or 5. Doing it regularly, say weekly or daily, in some trials can get very tedious for both people taking part. And I'll openly admit, for those people who are interpreting days and days of data in individual people, trying to unpick things. So 4 to 5 quality of life questionnaires is the general rule in a study that is designed to look at lots of different domains. There are trials where we include multiple other quality of life questionnaires, because that is the main objective, is it improving the quality of life? So for example, some of the anti-itch trials that we're running here in Birmingham have a multitude of other questionnaires, because the main objective is it improving itch, and is that improvement in itch enough to improve other domains sort of your lives. So when we chose these particular tools that Sarah listed, those were ones that, together with Martine and PSC support, we had sent through a bunch of ones that were what we call validated. So they've been developed, tried and tested with people that have PSC, not just in people with other liver conditions or other ill health conditions. And those were the ones that then came out. And we did the same thing for the inflammatory bowel disease questionnaires. And of course, the more detailed and the more complex a tool is, the more domains it will capture. But we don't want something that's going to take an hour each time to complete and then ask you to do that every single day. So that's why we had to balance what is realistic versus what you wanted as a group to collect.
Yeah, thank you. Quick question, I think. Do you foresee a Canadian study taking place in the future? You have strong links to Canada.
Yeah, absolutely. So Canada, other parts of North America, absolutely. I mean, it's not Canada, but in the States, Women's Health Organization have just received a huge grant with a colleague of ours called Jessica Allegretti to study fecal microbiota and fecal transplantation in people with PSC. And of course, in the United States and Canada, they are significantly richer than us as a UK group are in terms of their access to research funding. So they will certainly be doing studies in a similar vein. I'm not aware, however, of any PSC focused investigators in Canada who also have an interest in fecal transplantation, though. So certainly they are looking towards our trial, which is the first in the world, I think, to do this sort of study, and what the results are before embarking on their own endeavours. And I'm hoping that obviously our trial is positive in terms of its readout, and we can then help facilitate a multi-centre study as per the question a little while ago from somebody else.
Yeah, that would be amazing.
Yeah.
Shall we have a vancomycin question?
Yeah.
If the Fargo trial is promoting healthy gut microorganisms to make a positive difference, but the vancomycin trial may show some positive things by killing off gut microorganisms.
Yeah.
Are these two concepts seem different? So why is that? That's a good question. I like that.
It's a superb question, excellent question. So yes, there are a number of trials of oral vancomycin. So that's a gut-specific antibiotic. There are multiple trials of that in PSC across the world, and multiple studies that are not really trials, but they've just been given to people, and investigators have reported saying we gave it to somebody outside of a trial and this is what happened. And the results are quite encouraging, and the body of evidence continues to grow. And in fact, last week or the week before, there was a nice study from the Children's Consortium of International PSC Consortium, showing quite nice benefit of vancomycin in treating colitis. But the same group have shown that it doesn't improve liver blood tests or long-term need for things like transplantation. So vancomycin, is an encouraging aspect. We did a trial that PSC supports are fully aware of from last year, where we showed something similar. We showed an improvement in colitis activity. We did show some improvement in liver blood tests, but the trial would have to continue for years and years to show whether there was any benefit on long-term survival and need for transplants and other things. But what we do find with vancomycin is that it does some things that we think are not good to the gut microbiota. So it narrows down the diversity, so makes them slightly right. You want a very diverse, broad population, a very rich sort of diversity of stool bacteria sort of in your colon. And vancomycin, because it's an antibiotic, shrinks that down. The other thing it does, you want to have what we call secondary bile acids, because they promote tolerance and settling of inflammation rather than more primary bile acids, which what we believe so far cause sort of more inflammation. Well, not cause more inflammation, but they're less tolerogenic in your bowel. What we find with vancomycin is that, sort of, yes, it narrows down that sort of that bile acid pool, rather than broadening it out with those secondary bile acids. However, despite those two things, it does treat colitis and makes colitis much better. So what we learning from vancomycin is, just because it does one element which we think are not good, but the clinical outcomes are better, it means that different treatments to treat colitis can work through different pathways. And just because one drug does one thing and the colitis get better, doesn't mean that vancomycin is going to do the same thing and likely has a different pathway to make colitis improve. To answer the question about how do these two things are going to differ, there is some school of thought that if we give people vancomycin first and then you give a fecal transplant after, then that may be what the gut needs to improve, and not just the gut, but that's what the liver needs to try and improve. Now, a lot of that is several chess moves forward in thinking, because still to date we don't have a proper vancomycin clinical trial where they've compared vancomycin with a placebo group, a dummy pill group, to show that there's any added benefit based on colitis treatment versus nothing. We don't have a randomized control trial yet, and it's sort of before Fargo, of fecal transplant versus a dummy pill. And we're already being asked the question as to how do we mix and match these two things. So what we need to do is have both of those trials published, peer-reviewed in a scientifically robust way, and then we can, and if both of those are positive, then embark on comparative studies with, nothing versus placebo versus vancomycin alone, versus fecal transplants alone, and then vancomycin plus fecal transplantation. But that study I don't envisage happening for a number of years, certainly not before this this fecal transplant trial runs its course.
Thank you for that. Next question. I'm just looking at the time. We've got 10 minutes left, and we've got quite a lot of questions to get through here. So this, as it involves a lot of hospital appointments, for those patients that live outside Birmingham, can the 7-weekly treatments be administered at their own local hospital?
So that we will be running 6 sites across the UK. It would only be in those 6 sites that you could receive the treatment as part of the fecal transplant trial. Sarah, if I forget them, do remind me, but there will be 3 sites in London. There will be St Mark's Hospital, the Royal Free Hospital, which is near Euston Station, and King's College Hospital, London. Oxford and Norfolk, Norwich are the other sites, and ourselves. We do have what we call participant identification centres, where you can be screened to take part in the study and then referred to one of the other programmes. So that will be Nottingham, Leeds, and Cambridge. And we may open more further afield, but unfortunately you won't be able to receive the treatment unless you're willing to visit one of those 6 sites that I mentioned, the 3 in London, Oxford, Birmingham, and Norfolk, Norwich.
Thank you very much. Well remembered, all those. If the Fargo trial is successful, how long do you think it would take before PSC patients could start receiving this treatment? And a kind of similar joint question is, how long until Fargo provides some meaningful results?
So if we open Fargo, I mean, this week, for example, then we still have, the tall task of recruiting 58 individuals, which is actually a lot harder than it seems. I mean, we've got great attendance today on the Fargo, say, for their call. I can see that there's 46 people here. So if everybody who's here, if they're interested in it, wants to take part, we would still be shy of another 12 people to sort of to take part. So it's quite a big ask. Now the trial for each individual will run for a year, so we have set ourselves an 18-month target to recruit everybody. So that will take us to September next year, and then it'll be another 12 months after that, so September 2026, where we would have everybody completing the trial. and then it will take us another 6 to 12 months before we can analyze all the data. So at the very earliest, it would be looking at the end of 2026, well, very ambitiously end of 2026, which is only 3 months after completion, or very likely start of 2027. But clearly, if we recruit everyone very early, so if we recruit everybody this calendar year, we could have results as early as the end of next year. So anybody who's waiting for a colonoscopy, who is keen on a trial, I really encourage you to sort of join and take part.
You've got a colonoscopy that's due in 6 months from now, say, but you're eligible to go on the trial and your doctor agrees. Would you be able to still have your colonoscopy at the right time and start the trial then, or would you want them to bring it forward?
It's very dependent on what the individual feels. I mean, there's no right or wrong window. It's not an exclusion if you've had a colonoscopy in 3 months ago or 6 months ago. But what we don't want to do is to say to people, you've had a colonoscopy today, I also want you to do the trial to come back next week or 2 weeks, because that would be unethical and unsafe. So there's no, we haven't put that in stone. We haven't put that as a definite window. It's really for discussion with the individual who wants to take part. But if you say to somebody, if somebody's had a colonoscopy in December and they're due to have another and they're saying, actually, I really want to do this, I don't care, I really want to do it, well, that's fine. We would just have a very informed discussion saying, look, you've just had a colonoscopy. I know a lot can happen in the next few months. Let's book your date for coming in for screening for your colonoscopy at this particular time point. And we can say to them, look, okay, I'm not saying you have to wait another 12 months, but if you wish to have it earlier, let's book you in for a date in September, October, and plan things from there. But there are people who've had a colonoscopy 6 months ago who really want to do it, and we would have that discussion with them. And perhaps if they don't want to wait the full 12 months for their next scope, we would book them in slightly earlier, and there's nothing wrong with that. I mean, that happens in real life as well, although less so in the modern NHS, sadly.
Yeah. So if you have got to wait, if your next colonoscopy is in 6 months and you don't fancy having one earlier, but you want to take part, then
Still book you in.
You could just still register and hopefully get on time. Thank you. How long would the hospital visit be for when you have the enema?
So the enema, visit itself is very likely to be about an hour or so. So you would come in, you would have your enema, and then we would have to be sure that it's retained. So usually about an hour or so. We have specified in the sheet that it can be more than that, and it can be up to a few hours, but that's because we have to specify, it's sort of the maximum amount. But so clearly, when you have the enema itself, provided all is well within, say, half an hour or slightly longer, then that's absolutely fine. We don't expect everybody to retain all of the product from the enema, of course. So, but we would say about an hour or so is the average time we're anticipating.
But it's not a procedure that you have a sedation for and then you have to wait around. You can just have
it's just like any other enema that some people may have received for their colitis or to empty the tail end of their bowel during other types of lower gastrointestinal endoscopy procedure. And
when you have the colonoscopy, you have the bowel prep, which we all love. The specific sort, isn't there, that you're expecting for this trial? Is it the I don't know how to say it, the Movi prep one?
Yeah, so ones that are based around sort of MOVA prep, that's preferred.
And
that was mainly because when we canvassed opinion from the other trial sites, that's the one that they all use. So Plenview, MOVA prep, that sort of preparation. And if there are individuals who have, I mean, I shouldn't encourage this, especially because we're being recorded, but if there are other bowel preps that are very specific to you, so that individuals take, like sodium picosulfate or clean prep, we can discuss those if we find lots of people are on different bowel preps, and we can put an amendment in if needed. If we're finding that lots of people are really keen, but they don't want the MOVA prep, they always have a different type of bowel prep, then then that's something we can discuss on a case-by-case basis.
The Plenview one is a lot lower volume, so it's a lot better for people.
Yeah.
I did have another question relating to that, and it's just gone out of my mind. So we
Sorry.
call it PSC.
Plenview's fine.
Yeah. Oh, I've remembered now. You don't need to do a bowel prep, do you, for the enema? That's okay. You can just come in. Do you need
As
to
you are.
fast for that, or?
No, no, no. You come in as you are.
Yeah.
Preferably you've gone to the loo before you've come in, and then you have the enema. Yeah.
We've got IBD. That's not going to be a given. We can't plan that well.
Okay.
So that's that. How long will the hospital be? So I'm just trying to, I'm conscious we've got 3 more minutes. Can you apply for the trial if you're currently on steroids?
I would have to have a look, Sarah. I don't know if you've got the protocol in front of you. I think if your dose is stable, you might be able to, then I think the answer is yes, but Sarah's got it in front of her and I'm ashamedly don't.
Yes, so you have to be stable on the steroids for at least 12 weeks before screening, and you'll be fine to join.
Yeah, yeah.
Okay, thank you. Thank you for that. I think that we've run out of time now. There are some more questions, but we can save those for next time. But thank you very much for everybody that's been on the webinar today for asking brilliant questions, and thank you both for giving such comprehensive answers as usual. I hope everybody's learned something tonight, and thank you both for your time. Just to quickly say, the next Ask the Expert, it's another one from Birmingham actually. It's on Wednesday the 10th of April at 7 o'clock, and it's about PSC fatigue and how to manage it in everyday life with Alice Freer, one of the physios at Birmingham. So that's going to be really interesting and exciting. So everybody please just keep your eye on our website and newsletter for how to register for that. But for now, goodbye, everyone. Thank you very much for joining us. And thank you very much, Palak and Sarah, for answering all those questions. Thank you.